Hello, good morning, everyone. Today we have another interview with the American Society of Peripheral Nerve. We continue our series about the stroke spasticity management. Today we have a pioneer in that field, Dr. Caroline Leclercq. She is based in Paris and she is a hand surgeon and president of the Institut de Lemaine, internationally recognized for her expertise in the upper limb paralysis, especially spasticity and tetraplegia. She is trained under Professor Raoul Tubiana and Alain Gilbert, and she completed a traveling fellowship in the US, later becoming a consultant to 9 neurological rehabilitation centers caring for both adults and children. She is a pioneer in surgical spasticity care. She helps catalyze the field by organizing the first international symposium on surgery of the spastic upper limb in 2017 and continue to teach globally. Her publications include influential work on selective hyperselective neurectomy and a complementary review for nerve procedure for upper limb spasticity. Hi, Dr. Caroline. Nice to meet you.
Nice to meet you also.
Thank you. We are going to start. This interview actually, we try to make it as a guide for people who want to start their practice for spasticity management. And definitely we choose the best one to get the answer for. So we are starting with our first question. When you go back to your early career, what key experience or mentors that nudged you towards spasticity management, and how would you replicate if you were to start today again?
When I was beginning my practice, I joined this group, the president of which I am now, which is the Institut de la Main, and with wonderful mentors, and you mentioned them already. The goal there was to maybe try and develop some new fields rather than follow their paths and just replicate what they were doing. And at the time, there were not many people working in the field of spasticity. Actually, I should say there were very few. And going into the world of handicap was probably triggered with my early encounter with Professor Erik Moberg. He was a Swedish surgeon, and after his retirement, he dedicated his time to tetraplegia. And after meeting him, I decided to go and investigate into that field. There were at the time few people who were starting to operate tetraplegic patients, and following him, he was an eye opener for many people. He published his results, and then we all started to go into that field. The encounter with spasticity was later in my career. Everybody knew that it was difficult, that many attempts at surgery had failed, and that our colleague rehab doctors, neurologists were not keen on sharing the patients with us because they thought, at least for the upper limb, I am an upper limb surgeon, so I will not talk about lower limb. But in the upper limb, the tendency was to just wait and see and basically do nothing. And it's again through encounters and also maybe giving myself a challenge. Should we try and go into that field? That I decided. What would I replicate today? Well, I would be so happy to have mentors who can explain to me everything about spasticity and surgery in the spastic world. This would have saved probably 10 years of my professional life.
Yeah, that's very inspiring. So, as we mentioned, that this is mainly for people who really wants to follow your path and get more experience in spasticity management. So, for trainees and young surgeons, what is the most efficient pathway to start their like few steps in that pathway? Like, do you recommend like some courses, some observerships, some um, fellowships, or what do you recommend for them?
This is not a single answer. I think that first you need to read because now there are some data available. There are not any textbook telling you in case number one you do this, the case number two you do that, and there are many reasons for that. And one reason is that there is a lot of variability in the clinical picture, in the decision making, and in the outcome of spastic patients. So first read, and second, I think that companionship is the most important. Go and spend some time with people who do that surgery. By now, we have organized a lot of courses, symposia, events that people can attend. We have this symposium that you mentioned, which takes place every other year, that gathers all the specialists in the field. And the next one will be in Dublin, Ireland, next May. And there is also courses which I run, and I'm not here to uh, to do marketing for the courses, but this is a good way to learn. We do those courses take place in Budapest. There is a beginners course where we share everything between surgeons and rehab specialists, and we can come back to that later. And then there's an advanced course, which is only for surgeons and which is more a technical course. In both courses, we do dissections, and that would probably be an excellent way of starting your career. But the best is companionship.
I see.
Go and see what people are doing, talk with them, get experience from their experience.
I see. And for those courses, like, is it mandatory that they should start with the basic first before going to the advanced?
Yeah, well, this is part of the requirements. You
Mm.
you cannot attend the advanced course unless you have either attended the basic course or have excuse me, or have at least 3 years of experience in the field. It would
Okay.
not be wise, to try and attend the advanced course as a first experience because we already go
You should have
straight.
like a base of knowledge at least
Yeah,
to
you
enter
need you
in.
need a little bit of background
Yeah,
during these courses. Well, before these courses, we send a lot of reading material to all the participants so they can start an understanding what it's all about.
that's very fruitful words from you. And how do you advise the newcomers to structure like their practice as a spasticity clinic? Like you mentioned about the companion, that, but usually it's quite hard to go and speak to the. I think for the rehabilitation, still should be okay, but I think it's quite hard to convince the neurologist about starting such a practice, right?
Yeah, well, you should certainly start by communicating to your peers,
Mm.
communicating with neurologists, communicating with rehab physicians, communicating with physiotherapists. Occupational therapists are a big part of that field because they are the ones who are with the patients every day, and they know the difficulties, and they may help with the decision making. What I have found for myself most useful is going to rehabilitation center. In my practice, we don't have a rehab center attached to my hospital, and so you have to go to the rehab centers in Paris, where I work. The majority of rehab centers for handicapped people are outside of the city, and I have to travel sometimes 50 kilometers to get there. I work in two rehab centers which are more than 500 kilometers away. I don't work there every day, but this is how we have started communicating, discussing, and 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 uh, and and gaining trust from our colleagues to start this kind of work. My first encounter, this is a short story, but it's worth mentioning. My first encounter with children rehab centers was through a patient whom I sent to them after surgery. This patient needed rehab, didn't have a center to refer to, so I called the center and I said, "Could you take this child?" And them, by looking at the result, discussing with the parents, they said, well, probably there is something there that we can do, but they had to be shown what we
Yeah.
could do. What I have done in most of the centers where I now work with is at the first encounter, come with a little presentation explaining to them what we do, showing them a lot of videos, pre and post-operative videos, and that also is very helpful. I have to say that I now work with two colleagues because the workload has increased a lot, and among the three of us, we travel to almost 20 rehab centers. So
That's a lot. Yeah.
it's a workload, but it's absolutely worth it. It's worth it also for any decision making for any patient, because every patient is different from the other ones, and for every patient you need to ask yourself and your group a number of questions, and it's much better and it's much richer to answer with all the specialists involved in the care of the patient.
But your clinics are based mainly in those rehab centers, so you do only the surgery at your center, or like how does it
Yeah,
work?
well, most of these rehab centers don't have surgical facilities, so the patients come to my hospital for surgery. I do have a clinic in my hospital where I see patients who are not attached or involved with a rehab center. And decision making is always more difficult in that setting. I don't have the feedback from the people who take care of them, and it makes it difficult.
Okay, so is even like pre-post, you prefer that you see the patient within the rehab center, at least you have
Yes,
like
yes, absolutely.
mm,
So
yeah,
some people have in their hospital, they do have a rehab center inside the hospital, and I'm sure this makes things much easier, but this is not my case.
yeah, okay. I mean, makes more sense for sure. And what principles got your patient selected for goal settings among different ways of management for spasticity? Because there are so many things to do, like starting with Botox injection or like the fecal baclofen or the surgery or the therapy or all this. Like, do you have like a set of guidelines which you follow?
Well, it depends, how much time I have to answer this question, because it's a very
Yeah, I understand.
wide question. Um, I think that the principles is pretty much what I said before, which is working together, as a group, and making decisions together as a group with the patient in the center. Um, we now, and I think this is going to come in your next question, so maybe I'm not going to overlap, but you need time. You need
Mm,
time to examine these patients. As I said, this is not easy. They're all different, and there's a number of things that you need to evaluate before deciding on decision making. Now, goal setting for botulinum toxin, baclofen, orthosis therapy, this is usually done before I get to meet the patient. I never meet a patient who had no treatment. They
mm,
all, or most of them, have been through different courses of medical treatment, baclofen, botulinum toxin, and so forth. botulinum toxin we use in a very specific manner, and this will come again in the next question. I don't use it as a treatment. I use it as a diagnostic tool. So it's a very particular way of using this therapy. And for the rest, most of the patients we see already had baclofen, already had
Okay.
therapy, orthosis, and in a number of cases, they come to us after everything else has failed. And this is something which is um, not the right way, I would say, of looking at the whole treatment. I think that surgery is one part of a global treatment, including all the rest, but surgery doesn't come last. And this has been a mistake in the past. I think that we are coming out of it. But this has been a mistake in the past where rehab doctors would say, okay, well, we're not getting anywhere. Why don't we send it to the surgeon and see if he or she has anything to offer? And
Sometimes it's too late already.
usually it's too late, exactly.
Yeah. And so usually you don't come with a decision from the first visit, right? You need like quite few visits before you decide what you are planning to do for the patient.
I'm sorry, I didn't understand.
Usually your decision doesn't come from the first visit. You usually need like quite few visits before you decide what you are planning to do for the patient.
Um, that's true, but probably less and less because of the how do I say, reflective or respective education of our group. Because once you get to know a group, once you get to work with them, they start knowing my requirements. I know their requirements, and in groups which I've worked with for a long time, the patient comes prepared. They have an idea what they want, from the surgeon, and the botulinum toxin has been properly done. I mean, properly done for diagnosis purposes, or for pre-therapeutic purposes, and this is the ideal case, and I will see the patient. The patient has been evaluated. There have been videos performed. Toxin has been done, and we see the patient together and confirm. This is the ideal setting. In other settings where patients and teams are not so well aware of what surgery can provide, yes, we often have to see the patient several times, and very often I'm going to ask for another round of botulinum toxin for treatment purposes, not for pre-treatment, or for decision making is the right word, for decision making purposes.
So yeah, as you said, like there are two questions, like a bit of overlap. So you have like a checklist for your clinical exam, diagnostic, and functional goal mapping for the patient.
Yeah, we have over the years we have developed um, um, an examination form. Actually, it's one piece of paper, one sheet that resumes all of our clinical examination. It's very complete. It takes time. It involves very quickly the spontaneous posture of the upper limb, active, passive motion, strength of every group of muscles, and spasticity as measured by um, two types of tests, which are the well-known Ashworth test, which is very unreliable, and another one which is a null test, which stayed unknown for many years, which is called the Tardieu scale. So Ashworth and Tardieu for spasticity. And then we measure a number of other things, and every patient goes through this routine examination before surgery, at first visit, after toxin, before surgery, after surgery, and then every 6 months or every year. And this is how we've been able to understand what we were doing, to evaluate properly our results, and to come out with clinical papers displaying our results of this surgery. So that has been very important. And so what I need to stress here is that this clinical examination, first, is a key to successful treatment, and second is time consuming. Don't think that in 10 minutes you're going to be clear with what you can do for this patient. The first visit takes usually 45 minutes, and the following visit takes at least half an hour. So I think this surgery is probably not um, suited for people who spend their life running and who are in a hurry. It's really you really need to take your time, and this has proved very helpful by doing that, working together, taking time to examine the patient at length, discuss at length. We've been able to come out with decision makings which we've been happy about, and the patients, of course.
Yeah, for sure. So, um, what's your advice for early technical pitfalls for the new starters about injections and splinting? How we can avoid those technical pitfalls?
You're talking also about surgery,
Yeah,
both?
for sure.
Okay. So medical treatment, I think many of these treatments, non-surgical treatments, are interesting. The problem with the majority of medical treatments which have been offered for these patients are not permanent. You have to repeat the treatment every so often, and botulinum toxin is a great example of that. You have to inject every 3, 4, 5, 6 months because the effect of the toxin wears out. And sometimes, there comes a time to say, well, what else? Should we keep on injecting for 10 years, 20 years? Because those patients have a long life expectancy. Or should we try and find more permanent solution? And it seems like surgery is a more permanent solution. So that's a state of mind that I think some people don't have. It has also been shown that there may be some negative effect of repeating botulinum toxin for the muscles, and some muscles have undergone some fibrous
Changing.
transformation, which is something to worry about. About the injection themselves, I think nowadays you cannot inject without having support from either ultrasound or EMG studies. I have a slight preference for ultrasound. I think it's probably more precise, but some people who are very experienced in doing it with EMG support are very effective also. Um, and now for orthosis and therapy, it's a little bit the same discussion. As long as the spasticity is present and strong, orthosis are only partially effective. So all the same, when an orthosis fails to improve the situation greatly or reaches a plateau and then nothing happens, or very often the patient stops wearing it, that's a good sign because he doesn't see or she doesn't see any improvement. Whereas it may be bothering to spend the night every night with an orthosis. That's when the provider should start thinking about other solutions and not stay um, um, with their classical way of treatment. So I think this would be have an open mind and seek for other solutions would probably be the best advice to give to our colleagues.
Okay. So you mentioned about you went to the rehab centers and you start to talk to them to start to gain their trust and build your career. So is there anything else you have done to establish your work away from talking to the rehab centers? So, I mean, usually anyone wants to start in this field, he need to go and speak with some other to establish the work, right?
Well, yeah, I think I have pretty much answered this question. Sometimes for a young surgeon, who has not much experience, not much recognition in their own professional world. It's hard to go and introduce themselves, to a rehab center saying, "Hi, I'm Dr. Smith, and I want to operate your patients." That doesn't work.
Yeah.
So I think again, companionship is very helpful. I have myself gone to some to some cities, mostly in Europe, where I have introduced myself and a young local colleague, saying, "This is what we can do. This is the type of surgeries we can do," and sometimes operated a few cases with the young colleague to help them with the technical little difficulties. No, but it's not difficult surgery, but to help them build the practice. And so as soon as results come out and the rehab team see, what we can bring to the patients, I think that the trust builds this way. Another thing I need to mention is that we and that goes back to the question about pitfalls. The classical surgical way of treating those patients was to work with tendon and muscles, and it was mostly lengthening. This left out probably the most important part of the treatment, which was treating the spasticity itself. Because if you lengthen a muscle tendon unit, but you don't treat the spasticity of the muscle, there is a big chance that the you find a recurrence. So now we work a lot with nerves because this is the way to reduce spasticity. We do the technique you've mentioned, excuse me, of hyperselective neurectomy, which means that we are cutting part of the motor branches to a specific muscle. And that implies knowing the anatomy. So another thing which probably I forgot to mention in the starting of your experience is to know your anatomy. If possible, go to a lab, go to a training lab, dissect the nerves, dissect the muscle, know where your motor nerves are. There is many variations, so you need to be very aware of the normal anatomy and the possible variations. So that's also part of the things you need to be to be to do before you start this experience.
Yeah, this is very helpful for sure. And how do you manage the expectations for the patients, especially usually those patients, they have quite high expectations.
Oh, that's a difficult problem. I always start after examining the patients. I always start my discussion with them, telling them that this will never be a normal limb. And I repeat this very sentence several times during the explanation for surgery. And even though we do this and we do this a lot, some patients, some individuals still keep in mind this hope that they're gonna get back to a normal limb after surgery. So if I feel that the patient doesn't listen to me and still keeps this irrealistic goal, I would probably not operate on a patient because he's going to be disappointed. I'm going to spend a lot of time trying to help him, and in the end, this won't be effective. The one thing I I did not mention really is about operating children. If you talk about a CP, cerebral palsy child, he's been with spasticity and deformity all through his young life. And especially for those hemiplegic patients, they develop other ways, other strategies with the normal limb. And they're usually quite effective in leading their everyday life with just one functioning hand. And so there is a disuse of the hemiplegic limb, and this is hard to change, to change. And the younger the patient gets operated, the better it is in that respect. We often have to deal with adolescents, teenagers, and I consider that if you operate a patient after 12, 15, 16 years of age, it will be very difficult for the patient to be able to make use of the potential benefit we have brought them by surgery. So they can have, a beautiful looking hand with a beautiful opening, beautiful closure, a good pinch, a good elbow. But the path is pretty much lost. And it takes a lot of usually occupational therapy to reverse this and get them to regain those lost strategy. Actually, they're not lost. They never had it because they never made
Dependent
use
on
of
that. Yeah.
them. So one of the things that we really stress nowadays is try to operate children young. And when I say young, I'm talking about 5 or 6 years of age. And I think this is, if we can do that, this is a dramatic change in the result of the surgery, of the functional surgery.
Yeah, of course, because I think for nerve, especially, the time matters a lot.
Mhm. Yeah.
And so, in final, how do you see the future of this field?
The future, well, I forgot to mention one thing that I
Mm,
wanted to say along your questions is
mm,
for a beginner, you want to start. You said how to start,
yeah.
and I think you want to start with simple things.
Mm,
Uh, I can be more precise about that. The spastic elbow, it's usually spastic inflection, is in most cases easy to treat, and the results will be satisfying because it's a simple joint. Um, Muscles are pretty much simple muscles with only one function, and so you want to start with things that have proven effective in other hands where the results are pretty good, and this is probably something to think about. Another thing is about dystonia. Dystonia is different from spasticity. It looks like spasticity. Sometimes it's a bit difficult to determine the
appreciate.
difference, but dystonia is abnormal spontaneous movements, which are
Mm,
not controlled by the patient. Sometimes we see patients who have
mm,
this type of little movements, type of little
mm,
movements which are spontaneous when you observe them. And dystonia is usually not an indication for surgery or contraindication for surgery. So if you have any doubt about a possible dystonia, don't operate these patients to start with. You might run into great difficulties. Now, looking at the future, It seems like there is more and more hope in the nerve part of the treatment of spasticity. We had recently, last May in Barcelona, a whole meeting dedicated to the nerve part of the surgical treatment. And there is a lot coming up. There is new ideas, there is new experiences in that field. And I think that we are going to be moving on to more specific, patient-specific oriented surgeries dealing with nerves, rather than the classical muscle tendon lengthening or arthrodesis type of surgeries. I'm talking again about the upper limb. The upper limb is different from the lower limb, and so I think the future probably lies in there. Um, um, Artificial intelligence, I do not know. Certainly it's going to help, but when I see how different our patients are from each other, how difficult it is to build an algorithm. I'm often asked to build algorithms, and then when I produce one, it's huge, and people get lost because it is very difficult.
Yeah.
Again, we need
Every
to.
case is unique in itself.
Yeah, each case is unique, and I think so far clinical examination is the key. So maybe artificial intelligence is going to help us in the clinical examination, in the assessment. Like, I was saying that assessing spasticity itself, the spastic component of the deformity, is very difficult. Maybe we're going to get help through artificial intelligence. Maybe future EMG studies will be helpful. So far, they're very helpful for the lower limb, and that goes through all the studies they do during walking, and maybe the future is going to be easier, when we have better evaluation tools. But
Predict.
it's hard to decide how exactly we can get help.
Yeah, this was a lot of tips and tricks, and for newcomers to this field, and I'm sure everyone will have a great experience to listen to this interview because you mentioned a lot from all your experience and all your practice. This is really very helpful. Thanks so much for your time. We appreciate giving us some time of your very tight schedule, and we are very happy and honored to have you in this interview.
It was a pleasure discussing with you and talking about this very rewarding field. And I am hoping to encourage our young colleagues to come and join us and learn. And we are always happy to share and teach. And I forgot to mention one last thing, which may sound a bit strange, but however, I'm going to say it. The techniques that we use are extremely pleasant also because they are extremely varied. We work with bone, we work with muscles, we work with tendons, we work with nerves, we work with skin. And so we do a lot of very different and very surgery, which are very pleasant to do, and that adds to the pleasure of going into that field and helping spastic patients.
Yeah, definitely it's very pleasing to the surgeon, and we
Yes.
also what we do hope that is pleasing for the patients themselves.
Oh, absolutely. This
Yeah,
is all of this is done in the patient's interest, and we it's not always easy to discuss with the patients because they may have some cognitive problems, they may have some speech problems, and this probably requires experience to understand their level of understanding. What what they can understand, what's too hard for them. So be sure to ask simple questions. Be sure to that they understand what you are trying to explain. That's also another little difficulty in that field.
In that field. Yeah, I had the pleasure to meet you in a couple of events, and really I learned a lot from you.
Okay. Well, very good, very good. Are you yourself dealing with spasticity?
Yeah, we know we have a lot of patients here in Singapore. I think it's
Yeah.
even more than the other nerve related conditions. So I really quite enjoy a lot.
Okay, good, very good. Well, happy to hear that. Happy to
Thank
hear
you
that.
so much. Thanks for your time and enjoy your day. Thanks so much.
Thank you. Thank you very much. It was a pleasure.
Thank you. Have a good day.
Goodbye.
Bye bye. Bye.